This is Chapter 19, Rehabilitation of Wrist, Hand, and Finger Injuries. It will be a little counterintuitive when discussing the upper extremity and start distal and go proximal. Many times issues down at the distal end of the upper extremity are due to things on the proximal end. However, there is plenty that can go wrong in the wrist, hand, and fingers not related to what happens in the shoulder. Many of those injuries are due to the falling on an outstretched arm. We'll talk about those in a little bit. This slide has the bony and muscular anatomy of the forearm, wrist, and finger. Please review if you are shaky on the information on this slide. As this is a repeat slide, you have seen it before. I will draw your attention to a couple of components that are of special interest in this body region. Range of motion is important to ensure appropriate fine motor skills of the hand and wrist. Figures 1915 to 1922 on pages 559 through 561 demonstrate mobility exercise for the hand and wrist. You also need to provide specific resistance to this area, especially the fingers, to replicate activities of daily living or functional activities. Pages 550 through 558 give plenty of activities exercises to accomplish this goal, as well as some mobility exercise interspersed. Make sure to take a look through those pages. On page 559, figures 1912 to 1914 show closed kinetic chain exercises of the upper extremity. We discussed these in Chapter 12, so hopefully those are simply a reminder. Even though most athletic endeavors do not require closed kinetic chain activity of the upper extremity, these exercises can assist with neuromuscular control. See page 562. Just like any other body part, have the three basic phases of rehab. One consideration is that is really unique to this body area is the splinting you can perform in the acute injury phase. As we will discuss shortly, many injuries require specific splinting and mobilization to allow the body to appropriately heal. Knowing those techniques is important in healing those tissues. This final slide discusses many injuries we see in clinical practice. A simple non-displaced extra-articular fracture of the distal radius has pretty promising prognosis. With appropriate mobilization acutely, things tend to get back to normal. Remember how much time bone needs to callus and heal? This injury will be no different. As those variables around the fracture change, the complexity does too. Also, having an external fixator versus a open reduction internal fixation versus cast or hard splint recovery plays a part in how long recovery will be. Note these differences in acute healing on page 563. Wrist sprain is what we call wrist pain that is less serious than a fracture, dislocation, or complete rupture of the ligament. Those are ruled out and you can proceed as tolerated. You will find in this situation patients are sore and tender after waking up from sleep. If that is the case, it may benefit the patient to put a splint on while sleeping. No one really knows what they do while they sleep, and it is not hard for your wrist to get put in an awkward position for hours at a time while asleep. Splinting it prevents that. While it may not be comfy at first, it will probably help them feel better in the morning. The next injury is the triangular fibrocartilage complex sprain. The TFCC is the primary radial ulnar stabilizer. Injuries to this structure manifest from the floosh mechanism or hitting a bad shot in tennis or golf. Many of these injuries utilize surgical intervention. Go to page 565 in the book. The occupational therapist who wrote this chapter talks about her preferred splinting method. It is pretty elaborate. The picture is on page 562. Like many other things, you have to let the initial information after surgery subside. Some surgeons and hand therapists will be more or less aggressive. If you have a case like this, be sure to discuss the thought process with the surgeon before moving through a rehab. Scaphoid fractures happen quite a bit in athletics. They are not easy to catch either. I have had many that look like moderate wrist sprains. Plus, non-displaced fractures may not appear on X-ray for a while after trauma. After the immobilization, which will average about 6 to 8 weeks, protocol is similar to any other wrist injury. Lunate dislocations are the most common carpal dislocations. The book shows how this can be potentially reduced on page 570. These injuries tend to need a surgical fixation to maintain the integrity of the joint. The post-surgical rehab will be very similar to a distal wrist fracture. Hamate fractures usually occur on the hook of the hamate. Common mechanism in sports is a golfer hitting a tree while trying to hit the ball. There are many structures that are attached to the hook of the hamate, making them very difficult. These injuries tend not to get better easily. If participation becomes difficult, you could have the fractured fragment excised. Padding and activity modification are typical conservative measures. Carpal tunnel syndrome is something we have all heard about. If you deal with the general population in your future careers, this will be a condition you'll see. The syndrome is compression of the median nerve of the wrist. In the general population, it can happen with prolonged improper ergonomics and typing at a desk. Resting wrists on a desk or even on a soft rest can incite this syndrome. In athletics, tennis players and throwers are all vulnerable due to sustained grip and repetitive motions. Cyclists having rest on the handlebars can create this condition also. An injection is both therapeutic and diagnostic in this condition. Improvement after an injection can confirm the diagnosis. Splints are out there to help maintain appropriate hand and wrist posture. Those are not always used because they can create other problems due to muscle weakness and distributing forces elsewhere. Nerve glides and tendon glides are used to decompress the area of nerve injury. A ganglion cyst is a synovial fluid-filled sac. They typically occur on the dorsal side of the wrist. See page 574 in the display picture. It is not known exactly why they occur, but they tend to appear in activities with forceful hyperextension. Weightlifters, shot putters, wrestlers, and gymnasts are prone. Some may create discomfort prior to being outwardly apparent. The archaic treatment of these is where their alternative name comes from. Have you heard of Bible bumps? While I do not recommend hitting them with a Bible or any other book, typical treatment is aspiration. There is a chance of recurrence after aspiration. If chronic ganglion cysts occur, they can be excised. As the slide says, TC likes to call the boxer's fracture a Lambert fracture. It is not exclusive to that fraternity, but they tend to happen on a college campus on the weekends at night. As the name indicates, it happens when an object is hit by a fist. The fifth metacarpal fracture is from getting too much force during the hit. Nowadays, splints are used to keep it stable post-injury as opposed to a bulky cast. This splint allows fingers 1 through 3 to move freely while the 4th and 5th MCP joints are immobilized. The picture of this splint is on page 575. De Quervain's tenosynovitis is inflammation of the first dorsal compartment, compromising the abductor pollicis longus and the extensor pollicis brevis. This is usually derived from conic, radial, and ulnar deviation. Splinting for De Quervain's involves a radial gutter thumb splint. There's a picture on page 577 to demonstrate what that is. The thumb UCL sprain is usually caused by a violent abduction of the thumb. Getting a thumb caught while trying to make a tackle in football, or any athlete that tries to catch themselves and their thumb is put into an abduction position. With this injury, a thumb spica splint is used to keep the MCP joint stable. Many thumb spica splints are low profile, which makes them conducive to participation with appropriate padding and strapping. And the derivation of gamekeeper's thumb comes from Scotland, where gamekeepers were breaking rabbit necks by pressing their thumb and pointer fingers against an animal pinned to the ground. The mechanism where the ground causes excessive thumb abduction of flies. MCP dislocations are rare. Dorsal IP dislocations occur much more frequently and are much less significant. I have reduced these at the direction of the physician. Some physicians will have a more conservative approach than others, though. MCP dislocations are split at 50 degrees of flexion for 7 to 10 days. After that, progressive range of motion and light strengthening and more aggressive strengthening. PIP dislocations can be taped or wrapped with self-adhesive tape to splint. The biggest thing with these injuries is to ensure there are no fractures present. Jersey finger is a rupture of the flexor digitorum profundus. If there is a complete rupture, treatment entails either doing nothing or having a very labor-intensive surgery that leads to a very tedious rehabilitation. Most people opt for the conservative treatment because most function is intact despite the tendon rupture. The book does a good job detailing what goes into the post-surgical rehabilitation. After reading it, you'd probably think that living with a flexor digital and performance rupture is not so bad. Looking at the splint on page 584 will also have you think twice about surgical repair. Mallet finger is an avulsion of the terminal extensor tendon. Being hit on the tip of the finger by a ball, opponent, or anything else is a typical mechanism. The BIP is forced into flexion when it is being held into extension. As I hope you remember, the key to this rehab is the non-stop splinting for at least 6 weeks. If you even allow once the BIP of the involved finger to go into flexion prior to healing, the scarring is lost and you need to reset the time of immobilization. Once the splint is off, the press is tolerated. Nowadays, though, there are very low-profile splints that can allow for participation support while mobilized. However, the patient still needs to keep the injured joint in extension for 6 to 8 weeks of healing despite participation. The boutonniere deformity has a similar mechanism as the mallet finger. The central slip of the finger extensor is compromised here, resulting in PIP flexion and eventually BIP extension. Treatment of this is continuous splinting of the PIP and extension for at least 6 weeks. The BIP is allowed to move freely. After splinting is done, range of motion and strengthening are emphasized.